mastectomy followed by radiation, no reconstruction. And now it's like, okay, do I have options?
Yeah.
Absolutely. In that scenario, you're by far the best option is a flap, is a tissue reconstruction using a flap. And that's now you're bringing in healthy tissue from another part of your body. You do end up with a patch of skin on the reconstructed breast, because you can't take this healthy tissue and just open up your radiated scar and shove the tissue underneath and then close up the same scar. You need to add skin.
Tight and dry and everything, right? Or
Yeah.
would you use expanders or something?
No, we don't. No, you just replace.
Radiation
You just
plate.
replace it with
Okay.
healthy skin.
Healthy
So
skin. Okay.
yeah, so you replace the skin that you used to have and then was removed, or skin that you had and then shrunk from the radiation. You just basically bring in more healthy skin along with fat to reconstruct the breast under this extra skin, right? So in essence, you're replacing a lot of the radiation damage with healthy tissue. What doesn't work well is trying to put an expander under that firm radiated kind of, it's more leathery
area.
And then trying to stretch that out, even if it's successful, it can be quite painful. And even if you get a mound out of it, typically it's just this mound and not very aesthetically pleasing and not very breast-like in terms of a nice teardrop shape and a nice silhouette. And breast reconstruction has moved beyond just reconstructing a mound and a bra filler. I mean, we want patients to be able to wear a bathing suit and no one knows any different, right? So in terms of a nice result, really nothing compares with a flap tissue reconstruction. Delayed flap tissue reconstruction in that patient you mentioned, mastectomy followed by radiation, no reconstruction, and now they're looking at their options. That's the best one.
Wonderful. Thank you so much for expatiating on this. So what is the minimum time frame for any breast reconstruction? Okay, I wouldn't say any breast reconstruction, for saline implants and for the flap. What is the average? Because a lot of people get scared that they're going to be, under anesthesia for quite an amount of time after mastectomy.
Yeah, that's a good question. So again, it depends on the team that you've chosen. So teams that do this day in, day out are going to have shorter anesthesia times than teams that, the surgeons that don't do this every day. So implant cases, whether it's a staged implant reconstruction with an expander first or a permanent implant, those are going to be, typically if you say an hour for the mastectomy and an hour for the reconstruction, that's kind of a pretty good ballpark, I think, for most practices. Now, I'm very much aware and cognizant, talking to people from all over the place, experiences do vary, and there are women who had tissue expander reconstruction, and they were in there for 6 hours, right? So it varies, it's all over the place. Generally speaking, implant-based reconstruction, the surgery time is much shorter than a flap reconstruction. So less anesthesia time, and the overall recovery is shorter with implant-based reconstruction versus a flap. So for us, and again, the variability is huge. If you look at places that offer these microsurgical procedures, these kind of more complex flap procedures, I mean, there are places that quote 6 hours, and there are places you talk to patients and they tell you their surgery was 16 hours, right? It just depends on the setup.
Hours? Are you kidding me?
Yep. No, it depends where you are, to be honest.
Wow.
if you go to a place that does these day in, day out, they don't do, it's not a training facility, you don't have residents, your surgery will be done faster than a place where, it's a major academic teaching center. They have a big teaching program, lots of residents, fellows. That's how surgeons learn, right? That's how doctors learn. So if you have someone who's in that situation, it's not going to be as quick as going to a team that they're not teaching anyone, they're just getting on with it and they do it every day.
Absolutely.
So yeah, it's not rocket science, it's just familiarity and repetition. And so the variety in surgical time is huge. In terms of recovery, a typical implant reconstruction, I mean, I tell my patients 3 to 4 weeks for implants or tissue expanders. And then for tissue, I tell them 4 to 6 weeks. Now, the restrictions are pretty much the same during those times, but there's no question with a tissue reconstruction, it's a bigger deal. The level of support that someone needs has to be taken into account. You've got to plan for it, you've got to delegate, you've got to have a support structure. This isn't something you go into hospital and then you Uber home and you're on your own. We're talking about, probably can't drive for a couple of weeks. You can't go to the grocery store. You can't do laundry. You can't, so you got to plan. You have to have the right support structure. You got to have support from work. They've got to understand what you're going through. So it varies with the procedure, but generally speaking, those are those are the general time frames.
Time frames, yes. And I didn't want to, interject at the time you were speaking, but what do your multidisciplinary teams comprise of? Who do they comprise of?
Well, here, so we have the medical oncologist, the breast surgeon, radiation oncologist, plastic surgeon, pathologist, radiologist, and physical therapist / lymphedema, and geneticist.
Okay.
And nurse navigator, or actually several nurse navigators.
Those nurse navigators, they are really special.
Yeah, so those are the weekly players, because we meet weekly. And then, of course, in addition to that, you've got access to, nutrition and the other kind of adjunct services. Yep. But those are the main players. So it's pretty involved. And apologies to anyone I forgot to mention.
Cancer patients that are dealing with lymphedema, is there any advice? I mean, who do they see? Because usually when these lymph nodes are removed and then they have these issues, and most probably they also want to undergo breast reconstruction, would the reconstruction affect, or make their lymphedema worse, or how do they even treat it?
So patients need to be seen by lymphedema therapists. So these are physical therapists that specialize in lymphedema therapy.
In hospitals or in private clinics?
Either or, depends on the local setup. So there are some hospitals that have them as part of their physical therapy departments, and a lot of places just have lymphedema therapists in the community. We're very lucky. We have all that as part of our multidisciplinary breast center. So lymphedema therapy, unfortunately, tends to start, later than it should for most patients. Patients need to be evaluated early. The best thing to do, honestly, is to be measured before your surgery to know what your baseline is before you even have your breast cancer surgery, so that there's a comparison that can be made to see if your arm is retaining fluid afterwards and getting slightly larger. If you wait until you develop swelling, then you haven't started as early as you could. And a lot of the problem with lymphedema is patients have it and they don't know it because they don't really even appreciate they have any swelling, and they have they have achiness, and they just happen to kind of flippantly mention it, kind of almost like an aside, and they're not expecting any feedback from it, and then it's you pick up on it. It's like, oh yeah, your arm aches. Oh yeah, that was a side of your cancer. Oh yeah, they took out several lymph nodes. Oh well, you need to see a lymphedema therapist because you could have lymphedema. And that's very, very early stages, but that's when the greatest benefit can be had in terms of the conservative, non-invasive therapy options. Surgery can help lymphedema. So
surgery how?
Yeah, so in several ways. So going back to the lady you mentioned before who had a mastectomy, had radiation. So a person who has radiation typically has had lymph nodes removed. And so they may or may not have lymphedema, but let's say that lady also has lymphedema. So mastectomy, radiated, patient wants reconstruction, has lymphedema. Well, what we can do is, in conjunction with the flap surgery, let's say she's having a deep flap from her lower belly, we can also transplant some lymph nodes from the superficial groin.
Seriously?
And those,
oh my God,
yeah,
that's
yeah,
wow.
yeah. And then those lymph, and that's called a vascularized lymph node transfer. And then that's moved up to the armpit with the flap that reconstructs the breast. So you reconstruct the breast and you replace some of the lymph nodes in the armpit at the same time. What we also know is, even if you're not having a vascularized lymph node transfer, if as part of the breast reconstruction procedure, the plastic surgeon releases the scar tissue in the armpit, the scar tissue that has resulted from the lymph node surgery, that alone can help with draining the arm and decreasing the lymphedema. So, and then there's also another surgery called a Lymphatico venous anastomosis, or LVA, basically a lymphatic bypass. So what that is, and a couple of my partners do that surgery, LVAs. What they do is they basically bypass blockages in the arm. What happens with lymphedema is you get scar tissue buildup. The lymphatics,
right?
no, well, yes,
From
in the
the
armpit,
lymph
but
node removal.
yes, but also in addition, if you've got a backup of lymphatic fluid in the arm because it's not draining, then that itself can cause scarring in the lymphatic system. So sometimes you've got blockages in, and the lymphatic system is basically the body's sewage system. It removes fluid that the body is trying to repurpose, right? And so sometimes the lymphedema is caused by scarring in the lymphatic system, and so you need to bypass it. It's kind of like, you're going home, you're on the highway,
take the back roads, the back
yeah,
route.
and then you see, you come around, and then you see in the distance, you see a bunch of flashing lights, and you're seeing a bunch of brakes going on. You're like, oh, here's an access, I'm going to get off. And then you basically quickly get off. You make sure you don't hit someone in the process, because it's a last minute decision. You get off, you're on this access road, and you got off just in time. And then you drive past the wreck, and then after the wreck, it's clear sail, it's clear drive, right? It's all clear. I-10 is open. So then you get back on. So basically you've bypassed this blockage. So that's what a bypass does in the arm. And you can do several of these little bypasses in the forearm or in the upper arm or even in the hand. And that can be done either on its own or in conjunction with a vascularized lymph node transfer. So, and often patients that get both do better. We can also do liposuction for some patients. There there are other tissue transplantation techniques that involve not necessarily replacing the lymph nodes in the armpit, but taking those nodes, those lymph nodes, and actually transplanting them to the elbow or to the wrist even. There's all sorts of fancy stuff we can do that helps with the lymphatic flow. So that's another
I'll be reverting back to you regarding that, Dr. C.
We're here. So yeah,
definitely. Thank you for
we do
that
Oh, you're welcome. Yeah.
explanation. Honestly, I've learned so much. It's as if I'm an intern. This is more than being an intern, actually. There are so many risks when it comes to surgeries and everything. So how are surgical complications handled just in case that patient is not happy with their outcomes?
Yeah, you're right. I mean, surgery. So you can, any surgery is associated with risks, bleeding, infection, wound healing problems. In the case of a flap reconstruction, the tissue can not make it. It can, if the blood supply isn't good, then that tissue basically dies. So thankfully, in experienced hands, the risk of that is exceptionally low. It's less than 1%. So there's, over 99% success rate. But any complication is obviously potentially devastating, and it just adds to the, to the pain of the situation to the patient, especially during that time in their lives. So, complications can happen. Unfortunately, it's part of surgery, and it's all about having a good relationship with your physician team to make sure that if you do get a complication, that you feel comfortable they're going to get you through it, right? And then it's a team of. So we've been talking a lot about teams. That I think one misconception is to not include the patient in that team, right? The patient has to be central in that team.
Absolutely.
So when someone says to me, and it's a big concern for patients who travel to us, right? Obviously, because it's like, hey doc, I'm traveling from whatever, fill in the space,
New
can be
York.
anywhere. Yeah. So I'm traveling from New York. What happens if I get a complication? Well, what you're asking is, hey, dude, I don't live here. How are you going to get me through this? And the answer is, okay, here's what we're going to do to get you through this, right? Because there's got to be communication, there's got to be trust. So you've got to have a good relationship, because the physician or the nurse or the team is depending on the patient to follow through on their instructions. There's depending on the patient for information on which recommendations are made. It's a team thing, right? So physicians can't take care of patients who don't play their part.
Yes.
So we tend to think of more along the lines of, the physician dropping the ball, or, can I trust this doctor? But we also have to address the fact that patients are part of that team, and the patient and the physician or the healthcare team together get the patient through.